Thomas Baldrick here at ASH 2014. Happy to have with us Ajai Chari from Mount Sinai in New York. Thanks for stopping by, sir.
Thank you.
So tell us about this phase 2 study in multiple myeloma you're working on.
So this is a phase 2 study done at Mount Sinai Single Center, combining lenalidomide, dexamethasone, and panobinostat. It's a completely oral regimen for relapsed refractory myeloma. And I think just to put the study in context, as we know, the relapsed refractory myeloma is still an unmet medical need, and patients become refractory to every available therapy. And one of the classes of drugs that's been of interest is the HDAC inhibitors, specifically panobinostat. And everything in oncology boils down to risk and benefit. And so the first question is there any benefit of this drug? And the two studies that would give some credence to that would be Panorama 1, which is the global phase 3 study that's been reported recently, where patients were all received bortezomib and dex and randomized to receive either placebo or panobinostat. There was a approximately 4-month PFS benefit with the addition of panobinostat, which is obviously encouraging. However, there was also a significant amount of grade 3/4 diarrhea, 8% in placebo arm versus 25%. And so then it comes back to that risk benefit. Is that benefit enough to offset the risk? We'll put aside some of the new technical issues that have come up with the PFS question in that study. The second study that gives credence to the benefit is the panobinostat Panorama 2, which is panobinostat with bortezomib and dex. This is a single-arm phase 2 study in bortezomib refractory patients where the response rate was about 35% and the PFS was 5.6 months. So again, a signal in patients who normally would not be responding to bortezomib, but the addition of panobinostat got better outcomes. But there was again a 20% incidence of grade 3/4 diarrhea. So those are the two studies that probably have the furthest advance in efficacy. And the question is, what can we do about that toxicity? Because if patients are coming off due to drug and that's leading to shorter PFS, that's going to be a big problem. And so I think there's now 3 studies that we can speak to, and briefly I'll just mention 2 that were presented at ASH yesterday. One is upfront bortezomib, lenalidomide, and dex with panobinostat added, and very few patients had grade 3 diarrhea, only 2 out of 22. And what's different about this study is the bortezomib was given sub-Q, as opposed to both of those other 2 studies were IV twice weekly. And so I think what we're seeing is that part of the reason that diarrhea signal was coming up was because of the decision to give IV bortezomib at that point. And then to that point, there's the other study that was presented was carfilzomib with panobinostat, and there was no grade 3/4 diarrhea. If this was a panobinostat-specific issue, that would have come up. So I think what we're seeing is that it's not a drug-specific issue, it's a combination issue. And our study is the only one of these that's purely an IMiD-based, completely oral. There's no parenteral drugs. So this is oral panobinostat, oral lenalidomide, oral dex. And it was very well tolerated. We had no grade 3/4 diarrheas. We did not have any dose reductions for non-hematologic toxicity. The only dose reductions were for the expected myelosuppression when you're giving 2 drugs in combination that are myelosuppressive, but very manageable. And of the 19 patients now that is presented at today's poster, the update, the overall response rate was about 33%. The PFS was 6.5 months. And even if you drill down to the 14 patients that were lenalidomide refractory, the response rate was again about 22%, PFS about 5.5 months. And these numbers, when you have a response rate of that 20 to 30% and PFS in that 4 to 6 month range, that's in that sweet spot of where myeloma drugs need to be to get approved. That's where carfilzomib was and pomalidomide. And the difference is that our patients are even, some of them are carfilzomib and carfilzomib and pomalidomide refractory. So it really is an unmet medical need. And I think the body of evidence that we now have for panobinostat with these newer studies getting away from the IV bortezomib will mitigate some of the fears that patients and physicians and the community have about the diarrhea that's been reported. So I think there's a real need for this drug, and I think the convenience, the tolerability are really excellent.
So what's the next step?
I think the next step is, well, there's 2 issues. Novartis has to go to the FDA with this additional information, and if that moves forward, and if the FDA approves it based on the bortezomib, then I think we have one scenario. If that does not work, I suspect that Novartis will have to go back and do some other kind of registration study, be it with sub-Q bortezomib, with carfilzomib, or with an IMiD. And I think we'll see there that the PFS will probably be even better than it was in the Panorama 1 phase 3 study, because you won't have all the dose reductions and interruptions and the diarrhea issue. So I think once that's done, our studies that are being presented this conference will allow its use to be more broad than the registration approach, which is you can combine it up front to get deepening of CR. You can combine it with a proteasome inhibitor when patients become refractory. You can combine it with an IMiD when patients become refractory. And the idea would be that, kind of like the monoclonal antibodies, because this is a new class of drug, it's not just a me-too proteasome inhibitor or IMiD, but we'll have a way of overcoming drug resistance with these epigenetic or HDAC inhibition approaches to overcoming the drug resistance.
Nicely done, sir. Thanks for your time. Thanks for sharing.
Thank you.
Appreciate it.